Hi, this is Dr. Santhosh Kumar, Senior Lecturer from the Department of Prosthodontics, Vinayaka Mission Sankaracharya Dental College and Hospital. Today I'm going to just give you a brief intro about special impression procedures in distal extension RPDs. My contents for today's presentation, I'll be giving you a brief introduction. What is the need for a special impression, especially in cases of a distal extension scenarios? What are the different types of impression trays we use? What are the stock trays? What is the use of a stock tray? How will I be using a custom tray? What are the different designs of a custom tray? What are the impression materials which I'm going to use? What are the four different impression methods for recording a distal extension conditions and my references? So, before moving into special impression techniques for your distal extension removable partial dentures, we have to understand what a distal extension removable partial denture is. It states a dental processes that is supported and retained by a natural teeth on one end of the denture base segment and the other end by the residual ridge in which the portion of the functional load is carried by the residual ridge. So, very simple terms, at one point you have your teeth and the other point we have your residual ridge where your functional load is being carried. Young budding dentists should understand that the journey towards a successful denture fabrication begins with making accurate impressions. A good impression will make a removable partial denture retentive, stable, and more comfortable. Hence, according to the previous slide definition, we have to understand that a distal extension is where in which one part of the edentulous space or one side of the edentulous space has the teeth and the other has the residual alveolar ridge. So according to this Kennedy's classification, type 1 and type 2, which are classified as bilateral posterior edentulous, which is type 1, unilateral posterior edentulous, which is type 2, require the special impression techniques. Now there is a query. Why do we need to record the distal extension with a special type of an impression? The answer is it is because of the residual ridge. The residual ridge usually is in two forms. It's either in an anatomic form or a functional form. Anatomic form means whenever the ridge is in rest or at rest, and the functional form is whenever it is under load or under when we chew or under mastication. So what is the advantage of taking the residual ridge in a functional form or taking the impression of the residual ridge in a functional form? It is, first, we will have uniform support and there will be an equalization of your resilient and non-resilient tissue support. In this illustration, we can see a removable partial denture fabricated using an anatomic impression. Under occlusal force or under mastication, the distal saddle or the distal end of the saddle is sagging towards the residual alveolar ridge, and this is illustrated clearly. So now we might wonder why this is happening. This is because of an effect called resiliency. There are In this illustration, we can see a distal extension removable partial denture fabricated using dual impression, which is another type of a special impression where we can see the occlusal table remains the same even at rest or under mastication. The concept of resiliency has been achieved here because of the equilibration between the resilient and the non-resilient areas or zones of the residual alveolar ridge so as to get a uniform support. In a Kennedy class 1 or class 2 distal extension scenario, the scales are always tipped towards the functional impression techniques. So hence, a need for a special impression is mandatory. The term functional impression means recording the functional form of the residual ridge and to obtain uniformity of support when a functional load is applied, that is during mastication, or to obtain equilibrium between the resilient and non-resilient tissues of the residual alveolar ridge. The special impression techniques are also called dual impression techniques because we use two different types of materials to complete one impression. For anatomic impressions, that means to record the tissue undisplaced or at rest, we use either alginate or elastomeric impression materials. And if we want to do a functional impression, we have to make use of fluid waxes, metallic pastes, elastomeric impression materials, and soft liners. Under elastomeric impression materials, we might use addition silicon, condensation silicon, or polyether. And of those, we use the putty variety because the putty helps us to give more pressure and actually load the tissues under function. Many authors have come up with different ways of physiological or functional impression techniques, but MacLean's method, Hindel's method, functional relining method, the fluid wax technique, and the selective pressure technique are the most commonly used in the day-to-day scenario. For better understanding of how to fabricate a custom tray in distal extension scenarios, first the primary cast is taken and the outline of the special tray is marked. Before the self-cure is actually applied, a layer of wax is placed as a spacer so that it is easy for the removal, or we can also use a tin foil, which is not shown in this picture. So after placing the wax sheet or a double layered tin foil, the self-cure acrylic is molded on top of the tooth surface along the outlines, and the excess are cut and the tray handle is placed. The same is repeated for the mandible. Physiologic impression technique basically records the ridge, that means the residual alveolar ridge, in its functional form by placing an occlusal load on the impression tray during the impression procedure. So the first need for this physiological impression was proposed by MacLean, where he realized that the need for recording the tissues of the residual ridge in a functional form while capturing the remaining teeth in its anatomic form. You might see the difference in the outline of the custom tray compared to the previous illustration. Here, the occlusal rim is fabricated on top of the custom tray. Then the jaw relation is recorded. The occlusal rim is done for the purpose of recording your residual alveolar ridge in the state of function, that is when during mastication, when applying a masticatory force. Using this custom tray, a functional impression of the area is recorded. Most commonly used material is your green stick compound so as to get the functional impression. So the next step, once the functional impression has been recorded, the custom tray is placed on top of the residual alveolar ridge and the entire assembly is picked up with the help of an alginate impression, which is loaded in a stock tray. To sum up MacLean's physiological impression or functional impression, a functional form impression is taken in areas of edentulous ridges or edentulous space, and an anatomic impression is taken or picked up along with the functional impression. The glaring disadvantage of MacLean's method was that the finger pressure given during the pickup impression was not equivalent to the masticatory force, so the tissues were not displaced properly. Hence, Hindel came out with a modification, and this modification only involves your stock tray, not your custom tray. So it was the same procedure like before. So an acrylic resin tray over the saddle is prepared. An impression of the saddle area is made with zinc oxide eugenol paste. Before zinc oxide eugenol, it was powder molded, and it was recorded in its anatomic form, and a superimpression or a pickup impression is made with the help of a modified tray where we are allowed to give more amount of finger pressure. So this is the illustration showing the modification of the stock tray, which was this modification given by Hindel, where the doctor is directly or the dentist is directly allowed to apply pressure in those particular holes so as to displace your residual alveolar ridge and get the proper functional form. McLean's and Hindel's modification methods, they require physiologic impressions for support of distal extension denture base prior to the completion of the prosthesis. But it is also possible to obtain equally if not better results if we take these impressions after the fabrication of the removable partial denture. If the later procedure is followed, it is called as a functional relining method. Now, why do we need a functional relining method? Because in a functional relining method, the inner surface or the tissue surface or the intaglio surface of the removable partial denture is relined. Now, why is this important? It is important because once after the fit of the prosthesis, there is some amount of residual ridge resorption. So, when this residual ridge resorption happens, there is an improper fit of the removable partial denture. So, after the settling of the resorption, if the removable partial denture is relined afterwards, then it accurately determines the fit, and hence this method is called functional relining method. To reline the distal extension removable partial denture, there should be enough room for an impression material between the denture base and the residual alveolar ridge. So basically, there should be a space, and this space must be provided. So one of the most accurate methods of ensuring uniform space for the impression material is to adapt a soft metal spacer. This is also called ash number 7 metal. So it is placed over the ridge on the cast before processing the denture base. So once the denture base is processed, so it comes along with the soft metal spacer, and this metal spacer is later removed, and then this space is used for the material and it is relined. So here you can see the relief metal is being stripped off. These are done in two conditions: either when the fit of the prosthesis is not proper after the fabrication of a removable partial denture, or post the bony resorption or the residual ridge resorption after a period of time, and in either of these cases the metal has to be stripped and relined. After the metal spacer is removed, the low fusing modeling compound is added in increments over the tissue surface or the intaglio surface of the denture, and the border molding is done. Again, 1 millimeter of modeling plastic or your impression compound is removed from the intaglio surface. This is to provide the space for the corrective material which is used, and this scraping is usually done by a sharp BP blade. Most commonly used corrective materials are the fluid wax, zinc oxide eugenol, or any elastomeric impression materials, but the material of choice being an addition silicone, and that too a light bodied addition silicone. So, as you know, the fluid wax impression is used to make a reline impression for an existing partial denture or to correct the edentulous ridge portion of a master cast. So what are the objectives of the fluid wax functional impression? First one, to obtain the maximum extension of the peripheral borders while not interfering with the function of movable border tissues. And the second one, to record the stress-bearing areas of the ridge in their functional form and to record the non-stress-bearing areas in their anatomic form. So, so this is basically done with the help of an open mouth technique so that there is a less danger of over displacement. The unique quality of a fluid wax is that it is firm at room temperature and have the ability to flow at mouth temperatures. You all have to understand that this is according to ADA specifications where the room temperature is quite low in the Western countries compared to the mouth temperatures. Okay, and the most commonly used fluid waxes are Correcta wax number 4, which was developed by Dr. O.C. and S.G. Applegate at the University of Michigan, and Iowa wax developed by Dr. Smith at the University of Iowa. Now, while using a fluid wax, there are two important parameters, that is the control of two critical factors, which is your space and time. The space refers to the amount of relief provided between the impression tray and the edentulous ridge, and the impression wax actually flows very sluggishly, and a thin layer of wax will flow less readily than a thicker layer. So 1 to 2 millimeters of the space is very essential, and each time the tray is introduced inside the mouth, it must be remained in the oral cavity for a minimum of 5 to 7 minutes. Before placing the cast partial denture framework, you have to block or eliminate the undercuts, and this is done using a base plate wax and a layer of separating medium is applied. Bear in mind, here I have mentioned a cast partial denture framework, but in case of a removable partial denture, you have to use your custom tray. So on top of the CPD framework, the tray material is adapted, and after adapting, a 1 to 2 millimeters of relief is given between the residual ridge and the intaglio surface of the tray so as for the better flow of your fluid wax, and the tray border should be smoothened and a minimum of, and it should be shorter by 2 millimeters for recording the proper extent of the borders. After the custom tray is readied, a water bath is heated to an approximate temperature between 51 to 54 degrees Celsius, wherein the compartment of the fluid wax is kept and allowed to melt. The now molten fluid wax is painted onto the intaglio surface of the tray, where we already have a space of 1 to 2 millimeters, which is created by the spacer, and this proper assembly is seated in the patient's mouth and for a minimum of 5 to 7 minutes. And bear in mind, this is an open mouth impression technique or an open mouth border molding technique where you don't ask the patient to bite or displace the fluid wax in function. Here is the illustration of the completed impression. We have to check for the proper tissue contact, and the final insertion or the final settling time of the fluid wax is close to 12 minutes. So as soon as we complete the impression, care must be taken that the framework is handled with care and the new cast is poured as soon as possible, because we all know wax is very fragile and it is subjected to distortion, and this particular terminology is called warpage. Coming to the last impression technique of this lecture, selective pressure impression technique. This is a technique which attempts to direct more forces to those portions of the ridge which are able to absorb the stresses without any adverse response. That means if you place any amount of stress on a hard tissue, it should not undergo resorption. If you place any amount of stress on that particular soft tissue which is covering the hard tissue, it should not undergo any ischemic changes. And it also aims to protect the areas of the ridge which are least able to absorb the forces. That means you have to protect the areas which are vulnerable, so which can undergo resorption or ischemic changes. So that is why we know that the edentulous part of the mandible, the retromolar pad, and those particular areas in their vicinity, we know that the retromolar pad is a stress bearing area. So more amount of forces or the more amount of occlusal load must be transmitted to your retromolar pad, which is a stress bearing area. Likewise, your slopes of the residual alveolar ridge. The slopes of the residual alveolar ridge are also your primary stress bearing areas. So all the stresses which are concentrated in the mouth should be directed towards the slopes, but never to the crest of the residual alveolar ridge, because a crest is a point, a crest is a pinpointed structure. So any load on top of the of this particular structure will lead to a resorption of a alveolar ridge. After recovering your primary cast, the framework is tried on the cast. The outline of the framework is marked for the extension, and on top of this framework, an acrylic custom tray is made. Here we can see a framework with custom tray fabricated on it with holes on its ridge. If you look at the orientation of the relief holes, it is all directed at the crest of the residual alveolar ridge. So when we take a functional impression or when we take an impression, the excess material flows out of the relief holes, and that particular area, that is the crest of the residual alveolar ridge, is recorded in a state of rest. So as a result, we get that in an anatomic form, not in a functional form. So when it is not in a functional form, we do not transmit unwanted forces to the crest of the residual alveolar ridge. The areas in which the relief is to be provided is also marked on the intaglio surface, and with the help of a tungsten carbide burr, the relief is given so as to facilitate the material. The framework with the acrylic resin trays are actually tried in the patient's mouth. Following that, a bottom molding procedure is taken place. The bottom molding procedure is completed and a functional impression is taken. Bottom molding is usually done with the help of green stick compound, and your functional impression is taken either with the fluid wax or with the light body material. To conclude, I've given a briefing on the common clinical techniques for distal extension removable partial dentures. For further scope, kindly refer your textbooks, either McCracken's or Stewart's. Thank you for the patient listening, and I hope you liked it. So these are my references, as you can see. Last but not the least, maintain your hygiene and stay COVID free. Thank you all.